Okay, when you want, you can start.
Okay. I apologize for any delay, everyone in the audience. Welcome. And today, my topic is diagnostic errors in echocardiography. And though we can't prevent all errors, I'm going to try to show you ways that you can prevent as many as possible. So I have no conflicts or disclosures other than everyone needs to know that perfection is not possible, but we can practice in a way that brings us closer to it. And a couple of quotes: an error does not become a mistake unless you refuse to correct it. And from a TV psychologist from the 70s and 80s, she said, you need to give yourself permission to be human. And everyone knows to err is human. So we know we all make mistakes. What we want to try to do is mitigate them, not let them happen again, the same ones, and try to do it as little as possible or as infrequently as possible. So the goals of a pediatric echocardiogram are to do a complete anatomic assessment of the heart. The first time you image a patient, unless there are mitigating circumstances, you should try to do a complete exam. That means identifying all structural defects, or just all structures if they're normal, qualitative and quantitative assessment of the severity of the disease, known and unknown associations, and of course, pertinent negatives. We also do a functional assessment of cardiac performance. And one of the most important things about a pediatric echo is that we communicate the limitations of the study. That may be the limitation of the modality, if echo is not the right tool to be using to make the diagnosis, or obstacles to adequate imaging, a ventilated patient, a patient on an oscillator, a patient with an open chest, things like that. Medical errors are unfortunately incredibly common. Medical errors are preventable adverse effect of medical care, whether or not it is evident or harmful to the patient. And it's the third leading cause of mortality in the United States. There are 400,000 hospitalized patients where medical errors occur. And it's very hard to determine exactly the cause of death in all patients, but up to 100 to 200,000 patients are considered to die of medical errors in a year. Extraordinary. It's also very fiscally expensive, costing $20 to $40 billion per year. How do we define an error in pediatric echocardiography? Well, Oscar Benavides at Boston Children's has really done some seminal work in this area to help us make these definitions so that we can categorize errors to be able to figure out ways that we can mitigate them. So a couple ways he does that was looking at clinical impact, so minor impact, which is no change in the patient's management or course. And this can be, an example of this would be if you miss that the patient has a left superior vena cava to coronary sinus, but it has no prognostic significance. Moderate error is an alteration in the patient's management or clinical course, but not an adverse patient event. So for example, if you miss a patient has a patent ductus arteriosus, but it's identified in the operating room and the surgeon closes it anyway, so no harm done. And then a severe event, the ones we fear the most, contribute to patient injury, or the error contributes to the performance of unnecessary or additional invasive procedures, or in the case of catastrophic errors, contributes to the patient's demise. And this can be an inaccurate diagnosis that leads to an unnecessary procedure, things like that. Then we think about errors with regard to whether they're preventable or not. And so there are three categories of that: preventable, where it's very clear that we should have picked up the error; possibly preventable, meaning we may or may not have been able to within the limitations of our modality; and then not preventable at all is that we didn't image something that it's not possible for our modality to image. We then categorize errors in another way too, sort of what types of errors that we're making. So administrative errors are like you have the wrong patient, the wrong ID, the wrong height and weight, so you get abnormal Z-scores for the patient when you're making measurements. Procedural factors like that you can't complete the study, you can't do suprasternal imaging because the patient has a tracheostomy, things like that. And then some very important errors that we really can do something about are communication errors and the transfer of information. We may not be able to identify to the team what type of study needs to be performed, or importantly, we need to alert referring caretakers regarding very important or unexpected findings. Cognitive or knowledge errors are mistakes that are made in the interpretation of the imaging itself. Technical errors are when there's image artifact or incorrect settings on the machine, or again, limitations in the modality. And then there are patient-related factors. If the patient has a tracheostomy, if the patient has an open chest, if it's a micropremy, these all can affect our ability to image. So Dr. Benavidez and his group did a subsequent paper looking at the errors in their institution at Boston Children's. And they had a very low error rate, which is fantastic. I don't think they know the denominator, because you may not know errors if you don't know if the patient didn't really have a serious event afterwards, but they probably were able to detect all their very serious errors. And they found that about 80% of them were preventable or possibly preventable. The most common mistakes were cognitive, 37%, followed by technical, about 28%, and then patient-related, procedural, et cetera. And you can see that in the pie chart here as well. And when they looked at variables that were associated with errors, they were sort of what you would expect. Rare or very rare diagnoses had an odds ratio, the highest odds ratio of 6. And then high complexity congenital heart disease was another area where you could make errors, a smaller baby. And then interestingly, if the child was imaged at night or overnight or on the weekend, that there was a slightly higher risk of making an error in those situations. And that's probably because of incomplete imaging for the most part. And then intraoperative imaging, so transesophageal echo and epicardial imaging, has its unique set of factors. You're making decisions about the diagnosis under significant pressure and a very significant time limitation. And you, as an echocardiographer, especially if you're junior in your career, you can be influenced by the surgeon's opinion or the desire for everything to be okay. And this is an area where there can be significant communication breakdown between the surgeon and the echocardiographer, both with what procedure was done, as well as just the noise in the room, and the surgeon having to deal with many, many other things other than you as the echocardiographer, including making sure the patient's okay. And so sometimes communication is broken down, and that's a whole other talk I can give. And you also have a very poor imaging environment. There are lights, there's distractions, there's physical space abnormalities. So we recently, about 3 years ago, took on a multi-institutional study to try to determine what diagnostic errors were being made in patients undergoing congenital heart surgery and how we could improve this. So this was a quality improvement study, and it's presently under review. So our aims were to understand diagnostic error rate for preoperative echo in the current era and investigate the severity and types of errors that we're making, and then to ultimately relay the benefits of this multi-center approach to decrease errors. We defined an error in the operating room in patients undergoing congenital heart surgery as findings missed or inaccurately described on preoperative echo that is then identified either with additional imaging right before surgery or in the operating room at the time of surgery. We were able to enroll 14 United States pediatric echo labs in this study. And over a year's time, we looked at 1,476 consecutive patients undergoing congenital heart surgery. For this first round, we excluded single ventricle and some of the other more complex biventricular repair patients. And we did not find any significant associated patient or center-specific factors. In fact, if you looked at the error rate, the overall mean monthly error rate for this cohort was 7%, a total of 103 errors. And what you can see here is on the left side of your screen is in the dark columns, the dark bars, those are the total number of surgeries, and the lighter gray are errors. And you can see that there really isn't association with surgical volume with regard to error rate. And you can also see in the pie chart over here that similar to the Benavides study, about 75% of the patients had only minor errors, but that about 7% had severe errors. And this moderate to severe impact occurred in 19 of our patients. And of those 19 patients, you could see that it was more common to be a problem with AV valves or an additional VSD, and then the others are seen there as well. So how do we help in this situation? Well, it's very important to standardize your echocardiogram and to perform a complete study in every new patient that comes through the lab. If a study is inadequate and you have the opportunity, go back and get more images. And be sure to use appropriate settings on your echo machine. Use the right probe, appropriate gains, color scale, color sector placement, to make sure you have the highest resolution that you can have. We believe in recording complete loops and of complete sweeps of the heart, and then some additional information can be acquired with appropriate still frames. But the majority of the information should be obtained from complete sweeps of the heart, and it's very important to clearly state the limitations of your study. And if you really want to know what a complete transthoracic pediatric echocardiogram should include, I show you this paper that just came out through the American Society of Echocardiography, which is a guideline on how to perform a comprehensive pediatric echo that we were just recently able to publish. And it has all that information. All right, now I'm going to show you some cases of errors that have been made. And we'll start with the category of procedural and cognitive. So this is a newborn infant who was noted to have diminished pulses and acidosis in an outside nursery where we do imaging. So this imaging was done on an old machine. So I'll say the settings of this machine are not ideal. The person doing this echo was not a pediatric sonographer, was an adult sonographer, and did not do complete sweeps of the heart. So we'll just say that. The echo report said appropriately that there was concern for critical arch obstruction in this patient. And you can see here, as you're sweeping through the duct and the arch, that the transverse arch is very, very small. And in fact, is likely there's an interruption beyond the left subclavian artery. So appropriately, this patient was placed on prostaglandin and transferred to our institution. I show you the image on the right to show you that there was just a brief sweep done in the subcostal views of this patient. But what was missed when this was identified as a complete study. And so if we had just decided this was a complete study and sent the patient to the operating room, we would have missed something very significant. When the patient arrived, we imaged the patient again in our own institution. And what you can see here is that this patient, with more complete sweeps and better settings, has a known association with interruption type A, which is a large AP window, which you see right here between the aorta and the pulmonary artery. And in this sweep, you can see the AP window, very large AP window here. So that was completely missed on the initial study. And obviously, both of those things had to be repaired. So it was caught before the patient went to the operating room. So that's a possible preventable. So as far as cognitive errors go, you have to be sure you know when you're reading an echocardiogram that you know the patient's medical and surgical history well. If the question that's being asked about the patient is ambiguous or doesn't make sense to you, then you really should call the referring practitioner to clarify so that you make sure you get that question answered. Review previous echo reports and images when available so that you can know side-by-side comparison of what things look like and if they've changed. And one of the most frequent times that I personally have made errors in echocardiography is when I assume something, when I try to put something into a category, my gut feeling is that it's not right, but I'm just trying to force it in there. And that's really when you often make a cognitive error. And if the question isn't answered, if you have the opportunity, image more. If you don't have the opportunity, then you really have to communicate to the referring physician that you were not able to adequately answer that question. So here's a cognitive error with regard to know the operation. So this was a patient with unbalanced AV septal defect with severe AV valve regurgitation, who was pretty unbalanced and had LVOT obstruction. So the surgeon put in a fenestrated ASD patch, did an LVOT resection, and put on a loose pulmonary artery band. And here you see the perioperative transesophageal echo. In the operating room, there's some AV valve regurgitation on either side, not the worst ever. And then in the post-op day 1, you can see that actually the AV valve regurgitation, the gain settings are a little bit different, and it is transthoracic, but it looks a little bit improved. The AV valve regurgitation is probably in the mild to moderate category. And the LVOT obstruction is essentially resolved. And so the patient developed respiratory distress about 10 days later. This echo report on this particular echo was read as a small residual ostium primum atrial septal defect. But importantly, what had really happened here was that the patch had completely dehisced. You can see here that the patch is kind of flopping around. It's actually a very large communication that's occurred as a result of that. Essentially, the whole repair came apart. And you can also see that this patient has now severe AV valve regurgitation. If the echocardiographer had gone back and looked at the post-operative echo, they would have seen that this was a big change and that the patch looked very different in this study compared to the previous one. This was not identified for a couple of days afterwards, and then the patient was re-imaged where the dehiscence was identified and ultimately went back to the operating room. There can be errors of underinterpretation and overinterpretation. So let's go through some underinterpretation guidelines. So in order to avoid underinterpretation of a study, you should really know normal and its variants well. So for all the echoes you read in complex congenital heart disease, you should be reading thousands and thousands of echoes on normal patients so you really understand normal well. And you have a checklist in your own mind to assure that you can make sure that you have identified all structures. You should assess any relevant abnormality and know its associated findings, so that's a knowledge-based issue. And don't forget to focus on areas other than the primary problem. Where you'll see errors made often is that the primary problem is focused on so much that you miss something going on somewhere else. And if a piece doesn't fit, you need to really investigate further. And you can always get help from one of your more senior echocardiographers, particularly if there's something that you haven't seen before. And then I also want to make the distinction between a structure that you're not seeing well, but you know is present, versus suspecting a structure is not present at all. So that's a very, very important distinction. All right, here's a couple of cases of underinterpretation. Here's case 1. This is a transesophageal echo in a patient with tetralogy of Fallot who was having cyanotic spells, underwent repair, and here's the TEE. In this 4-chamber view, you can see there's some tricuspid regurgitation in this patient after the repair. Biventricular repair looks biventricular function looks quite good. The surgeon, because of the tricuspid regurgitation and the thought that maybe the VSD patch had altered the tricuspid valve in some way, decided to go back and repair the tricuspid valve and took down the VSD patch. And so they went back, and this is the post-operative transesophageal echo, second bypass run. I'll just tell you that the tricuspid regurgitation was improved, but you can see that the right ventricle doesn't look as good. The function's a little bit decreased. And the echocardiographer was very focused on the tricuspid valve repair and the surgery there. And this finding went completely unnoticed in the operating room. And so you can see the ventricular septum here looks very, very funny. And what this was what we call a septal hematoma. So blood, I'm just going to go back to this image. A coronary perforator gets caught in the stitch and bleeds into the ventricular septum and causes this problem. It's basically a huge bruise in the middle of the heart. This patient ultimately developed hemodynamic instability, and then this echo revealed that the patient indeed had had a septal hematoma, which, if you look back, you could see on the transesophageal echo. And this was done in the CICU. This is an uncommon finding. Patient was placed on ECMO. Ultimately, it resolved, and the patient was able to be discharged home. So just beware of that. Here's another example of underinterpretation. This is a patient with supracardiac total anomalous pulmonary venous connection, repaired in the newborn period. And again, the transesophageal echo was focused on the confluence and its connection to the left atrium and making sure that was unobstructed, which it was. There was some cyanosis noted in the operating room, but it was thought to be due to lung disease. So the patient was taken back to the cardiac intensive care unit with the notion that there was some cyanosis, the repair looked good, and they would deal with that in the CICU. But the cyanosis persisted in the CICU. And so ultimately the patient was imaged again by transthoracic imaging, and the echo was actually done to rule out pulmonary venous confluence obstruction. That's what they thought was happening. But if you watch here, you'll see the IVC making its way up and actually is connected to the left atrium. So the surgeon mistakenly thought the eustachian valve was the atrial septum and attached the eustachian valve to the atrial septum such that the IVC was entering the left atrium, which you can see with this bubble study as well. You can see the bubbles coming up the IVC and going primarily into the left atrium. There's a little PFO, so some of the bubbles are coming across. If you look back at the intraoperative imaging here, you'll see there are the pulmonary veins, and then you'll see the blue of the IVC actually making its way into the left atrium. And so this could have been identified in the operating room. And so what we do now for all patients who have atrial surgery is we put an IV in the foot and we inject contrast in the IVC to assure that this has not happened. So that's how we changed our protocol to prevent that error from happening again. And here's a third case of underinterpretation. This is sort of going down the pathway of thinking that you have a preconceived bias of a diagnosis. So this is an 11-year-old with tetralogy who had had a pulmonary valve replacement 1 year prior, presented with fever and increased inflammatory markers, and this was during the COVID epidemic and pandemic, and so it was presumed to be a diagnosis of MIS-C. The echo was read as no vegetation, so here you see some tricuspid regurgitation, and you can see that the pulmonary valve there looks a little thickened, but it was read as looking okay. The peak instantaneous gradient across the valve was 45. It should be noted that the previous echo of the patient, which had been done 3 months before, had a gradient of only 15. So big difference in the gradient. But this diagnosis of MIS-C was persistent in the minds of the people treating the patient. The patient continued to be unwell despite the MIS-C treatment. And a follow-up echo only 48 hours later showed a big difference in what this valve looked like. Very, very thickened. And the gradient had doubled in just 48 hours. So this patient had actually endocarditis, severe endocarditis. You could see what the valve looked like. By the time the patient made it to the operating room, the valve was almost completely sealed off by these massive vegetations that were seen. So beware of the diagnosis. Always sort of think outside the box when things are not making sense. You can also overinterpret an echocardiogram. So again, it's very important to know normal and its variance well. And if you identify something that you think is worrisome or abnormal, you really should be able to see it in two views. If you can't see it in two views, it's probably not real. It's probably an artifact. You should know the limitations of echo, including resolution issues and as well as ghosting. And again, if you are concerned about something and it doesn't make sense, you should always phone a friend, somebody who's a little bit more seasoned. And recognize that if you overinterpret an echo, it may mean more testing and more treatment of the patient. One of the most common overinterpretations is identification of thrombus in the heart. I've seen this happen over and over again. So thrombus, if you're trying to identify if someone truly has a thrombus in the heart, you must see it in at least two views. It also has to have, for the most part, a clinical context. There has to be a reason why the patient would have thrombus in the heart. And it's important to try to distinguish thrombus from myocardium, and sometimes that can be difficult to do. Thrombus tends to be quite mobile, particularly when it's on valves, and so that's an important thing to look for. And if you're going to decide to treat a patient for thrombus in the heart, really, in my opinion, at least two echocardiographers should agree that it truly is thrombus, because there are real downsides to treating patients with anticoagulation if they don't need it. And here's an example of that. This is a patient a 6-month-old who underwent a Yasui procedure for VSD with interrupted aortic arch. And what you can see is here's the neo-aortic valve. And you see this structure here under the neo-aortic valve. Here's the VSD patch. And this was identified, this was the post-op study before discharge. Patient was doing well. This was identified as a new thrombus, this thing adjacent to the neo-aortic valve. But in fact, it was not that at all. The patient was started on anticoagulation and developed bloody stool as a result of that. But what in fact this is just the muscle of the subpulmonary conus. The patch, the VSD patch, is adjacent to the free wall. And so you see this extra piece of muscle sitting under the neo-aortic valve, which is simply muscle. And it looks the same as the myocardium. There's no flickering. This was not a clot. And so the anticoagulation was discontinued and the patient was sent home. In contrast that to this patient who has true thrombus. Again, know the surgery that was performed. In the initial postoperative echo of this patient who underwent a Fontan, the person reading the echo assumed that it was an extracardiac Fontan. And when you have an extracardiac Fontan, you can see thickening of this region of the Fontan baffle because that includes the right atrial wall. But in fact, this was a lateral tunnel Fontan, and it should never look like this. So a couple of clues to the fact that this was real is that you can actually see the edges of the true Fontan baffle here, and this entire ring here is thrombus. And the other thing that helps clue you in to have, if you have Fontan thrombus in the Fontan baffle, is if you see that the fenestration is getting smaller. You can see how tiny the fenestration is in this patient where the arrow is, or closed off completely. So if the saturations go up a little bit in the postoperative period, you no longer have a fenestration, you should always worry about thrombus there. So the other identifier is that you could see a small flickering object, and that's usually bad. It usually indicates that there indeed is thrombus. And again, we talked about the fenestration. So this was true clot. The patient had to go back to the operating room and have all this clot removed from the Fontan baffle as well as the branch pulmonary arteries. All right, the last part of the talk, I'm going to talk about echo findings that are easy to miss. So the areas where we're going to miss things, and we've all missed things, are abnormalities of the systemic veins, of the pulmonary veins, coronary artery anomalies, pulmonary artery anomalies, and additional VSDs in the presence of a large VSD. Those are just the common ones. So when you're imaging the systemic vein, some helpful hints. Make sure you show the IVC entering the right atrium in all new patients. And as we discussed from the patient that I just showed you where the IVC was baffled to the left atrium, be sure the IVC enters the right atrium after atrial surgery. And using a contrast agent in the foot is a really good way of assuring that. You should not assume a structure is there. So I've seen people miss absence of the right superior vena cava because they just assume it's going to be there. And you shouldn't assume a structure is not there, such as a left superior vena cava to coronary sinus. You should identify the coronary sinus in all patients, and if it's dilated, you need to find out why. It may be a left superior vena cava to the coronary sinus, which is a benign finding. But if you have an unroofed coronary sinus or partial or total anomalous pulmonary veins to the coronary sinus, obviously a different story. And then the edges of the mediastinum and suprasternal imaging are really important to look for structures going up and down that may be abnormal. So here is an example of a subcostal view where you see the right upper pulmonary vein too well. And the reason you see it too well is because there's no right superior vena cava sitting anterior to it. And in this other image, this was a patient with hypoplastic left heart syndrome. And imaging the left side of the mediastinum, you see that there's a structure going up to the innominate vein. And that structure turned out to be a patient who had coronary sinus os atresia. And so the coronary sinus flow went up into the innominate vein. So that would have been completely missed if we did not look at the left side of the mediastinum. When you're imaging the pulmonary veins, assess all pulmonary veins if possible. And if you cannot, it is very important to report the ones that you cannot see. Look for places that they can drain anomalously, just like I said, like the left side of the mediastinum, but also the SVC and IVC hepatic veins. And beware of partial anomalous pulmonary veins in Turner syndrome. So patients with Turner syndrome often will have partial anomalous pulmonary venous connection. And then in patients who have meso or dextrocardia, you should always look for scimitar syndrome. And I think I've talked about this in my pulmonary veins talk in the past. So here is a newborn with mesocardia and pulmonary hypertension. You'll see in the sweep that the heart is sort of directed downward. And the right lung was small. And on a careful examination, you could see, in fact, that the patient has a pulmonary vein, right lower pulmonary vein, that is connected to the inferior vena cava there. So always think scimitar. Excuse me, I'm so sorry. In newborns with mesocardia or dextrocardia. And I told you about Turner syndrome. Here's a patient, a 12-year-old with Turner syndrome, multiple echoes in the past, had a coarctation repair in infancy, and it was always noted in the echoes that the RV was dilated, but no etiology was questioned or asked about until finally the patient had suprasternal imaging. And you can see this person had left upper pulmonary vein to innominate vein as the cause of the right heart dilation. So always think about partial veins in Turner syndrome. Coronary artery anomalies are challenging for us to diagnose by echocardiography because of the resolution of echo. And it is very important to understand, and your take-home message is still frame images are not diagnostic for the coronary arteries. You need 2D clips and color flow images to assess the direction of flow. And there are many recesses between and surrounding the great vessels that can easily be mistaken for coronary arteries. And it's very important to understand that even if you have a coronary artery abnormality, such as Al Kappa, anomalous left coronary from the pulmonary artery, I can assure you the coronary can look completely normal. And this is a limitation of echo resolution. So it's very important to understand that if we see the coronary going into the pulmonary artery, we can rule in a coronary anomaly such as Al Kappa. But we truly can never rule it out. And so often another modality will be needed to make this diagnosis if we think that the coronaries look normal. So here's an example where the heart looks just like a patient with Al Kappa. You can see a big dilated heart, 3 months old, who had presumed cardiomyopathy. But you can see the echo brightness, the dilation of the ventricle, the echo brightness on the papillary muscle, the mitral regurgitation. For all intents and purposes, this patient has Al Kappa until proven otherwise. The patient had imaging of the coronary artery, and the person who read this echo was very convinced that the coronary artery was arising from the aorta. There even looked like there was some antegrade flow in this patient, and so that was what was thought, but we pursued further. So evidence of ischemia, question about the normal coronary. In fact, this patient had left coronary artery osteoatresia. The coronary artery never reached the aorta. There was no connection, and this was seen on angiography. And so we could not see a coronary going into the pulmonary artery because one was not going in there. And so this is an important diagnosis that can be missed when you are arrogant enough to think that you can always see the coronaries by echocardiography. And it's a big miss because that is a surgical diagnosis that needs to be treated in the operating room. Pulmonary arteries, make sure you can see both branches. Parasternal, short axis, suprasternal imaging are helpful in that realm. They can be challenging to visualize, particularly the left pulmonary artery can be challenging in moving patients in particular. And in single ventricle and Glenn patients, we often have trouble seeing the branch PA as well. But you should know when anomalies are expected. So airway issues can be an indication that the patient has a vascular ring or an LPA sling. And we often see branch pulmonary artery abnormalities in patients with 22q11 or DeGeorge, 22q11 deletion or DeGeorge syndrome, or an Alagille syndrome. So here's a patient, 3 years old. Echo was done for a pulmonary stenosis murmur. The echo report says the LPA was not well visualized. Since the patient was 3 years old and moving around a lot, the thought was, okay, it wasn't well visualized. And that's a very important thing to distinguish. It was said as not well visualized, not that it wasn't seen. If you look here, you really don't see a left pulmonary artery at all in this patient. The patient returned for follow-up because the patient had developed pneumonia and was fortunately echoed again. And now you see what the problem was. This patient has a left pulmonary artery sling. You can see the sling coming around the trachea there. And it was completely missed. Now, if the person had said, I don't see the left pulmonary artery, we need further imaging to determine that, then we would have been able to pursue that further. But here they said it wasn't well seen. And so the referring cardiologist assumed it was present and just not seen well. Big difference. Additional VSDs are often missed in our patients, the ones undergoing surgery. You should really scan the entire septum with and without the color sector in multiple views and look at the extreme ends of each view, because you can always have very anterior, very posterior muscular VSD. And you should assume that there are additional defects and prove it wrong. And for infants who are now imaged at birth because they have preoperative diagnosis, you really should re-image in a few days after the PVR is dropped, because you can absolutely miss VSDs in the first few hours of life. So here's just an example of that. Here's a patient with a perimembranous VSD. When we sweep down, the color sector is not really getting the extreme ends of the ventricular septum there. And it turned out on further investigation, when you go to the extreme ends, you can see that this patient has a very posterior muscular VSD that would have been missed if we didn't pursue that further. So how do we avoid echo errors? I keep saying this, but it's true. Know normal and its variance well. You should really try to avoid preconceived bias. I think that the most errors that I've made in echocardiography are when I had that preconceived bias. You really should pay attention to your gut when something doesn't feel right and really pursue it. It's very important to communicate effectively, both positive and negative findings. You should, when an error is made, you should admit that error and have a transparent workplace where everyone can learn from the errors that we all make. You also need to learn how to forgive yourself and learn from your mistakes, and get involved in quality improvement projects to help mitigate these errors. It's important and hard in an echo lab to avoid distractions, mitigate fatigue, and it's really important not to be arrogant in the setting of our care of our patients. They expect us to do better than that. And when you don't know, or you're concerned about something, or you're going to make a big change in a patient's care as a result of what you're going to identify, you should always seek a second opinion on important findings. There's always colleagues around, hopefully, to help you and guide you. Thank you very much for your time. Sasha, you there? Thank you, the people in the chat.
Hi, Mary. Sorry,
Oh yeah, I couldn't hear you, Sasha.
Yes, I come back. I have problem with connection. You know the problem.
Yes.
So you have a lot of question in the chat and in the. There is a question about Al Kappa, probably.
About what? I don't see the question.
You cannot see the question? Yes, if
I
you go on chat.
I see the chat. Oh, question. Okay. How do we differentiate ledocardial vein from coronary artery osteoatresia? It's very challenging, and it's very controversial what people call these things. The coronary osteoatresia is the finding that's causing the levoatrial vein to arise. So there are veins that come from the left atrium or from the coronary sinus as a result of obstruction somewhere. We see this in two settings: in coronary osteoatresia, right, because the coronary venous blood has to go somewhere. And the other setting we see this type of vein developing that's going up away from the heart is in hypoplastic left heart syndrome with intact atrial septum. And in those patients, many of those patients, a vein will develop that makes its way back to the right atrium, usually up the left side of the mediastinum somehow. I don't think it's terribly important to know exactly what that vein is, other than that you identify that it's there and what the cause of it is. I hope that answers your question, Jason.
Exactly. There is a colleague that say that they have similar case about Al Kappa. What you show for Al Kappa. Yeah.
So I think I've done coronaries with this group before. I think there's a coronary webinar that I've done, and I teach my my fellows, my trainees, and sonographers to be very wary of our diagnosis of Al Kappa and coronary osteoatresia, coronary artery osteoatresia. Maybe that's what Jason was asking. So if that's what he was asking, my apologies. So when you see an echo that looks like the one I just showed you, where the LV is dilated, there's echo brightness to the papillary muscles, but you convince yourself that the coronary is normal, you have to convince yourself out of that. So what I would say is, you can make the diagnosis. If I see a coronary artery going into the pulmonary artery, you don't have to do additional imaging. You know you have Al Kappa in the setting of an LV that looks like that. But if you are convinced that the coronary looks normal and the LV looks like that, you need to do additional imaging to assure yourself, because we have been fooled many times that the coronary can look, because the coronary passes the aorta within a millimeter of it, and we just don't have the resolution to be able to detect that. And if you have coronary artery osteoatresia, you won't see the coronary going into the pulmonary artery, and you won't have that clue. So that often requires either an angiogram or CT to make that diagnosis.
Someone asked about transesophageal.
Yeah.
For Al Kappa, what do you think?
It's the resolution problems are the same.
Yes.
I would not make the diagnosis by that.
Okay. There is a lot of compliments for you.
Someone said you put a central venous catheter in the leg.
Yes.
In every ASD patient now. Yeah, not a central venous catheter. We just put an IV in the foot when we know that the patient's having an atrial septal defect closed. Yes, we do, because we have run into that problem more than once. Yes. The surgeon also, as you know, Sasha, needs to put the cannula to make sure that they see the IVC.
Exactly.
Right? So it's a double, the double way to assure that there's not a problem. However, I've seen it happen, not only at our institution, many other people have told me about this experience. And so we know it can happen. So it's important to, this is a very easy fix to make sure you identify that in the operating room.
There is a question about if you tell us more about coronary artery fistulas.
Oh, coronary artery fistulas. Well, that's sort of out of the scope of this particular talk, but I would refer you to the coronary artery talk that I gave on YouTube that is available to you that does talk about them. So someone said we could definitely see a left coronary artery that seemed to come from the aorta in normal Doppler direction, but due to apparent septal sinusoids, coronary was suspected. Al Kappa was diagnosed in the cath lab. Right. There we go.
Exactly. What should we do with the
You're making my
echogenic?
point. Thank you.
Yes. They ask about echogenic foci. What should we do with
echogenic foci? Is that what you mean?
Yes. Yes.
Yeah. So this is where experience comes in. There are often echo brightness within the heart in multiple areas that are often diagnosed as clot and are not. What I would say with echo brightness is sometimes you see them on the chordae, sometimes you see them on the papillary muscles. And it's important to look at patients' previous studies to see if they were there to begin with, and you're just identifying them better on today's study, for example. And then the clinical context is really important. If the patient really has no reason to have a clot in the heart and you suddenly see something there, then the likelihood that it's a clot is extremely low. Clots happen in patients who have significant dysfunction, in those who have lines within the heart, in those who have, potential vegetations, in critically ill patients, in patients with coagulation disorders. That's, or DVTs, things like that. We don't see clots in a normal person walking around who you happen to see a echo bright spot on. So I think that we overdiagnose thrombus in that setting.
Yes. Okay. I think we have answered to all the questions.
Okay.
Yes.
I appreciate all the comments. Thank you all so much. I'm really sorry for the technical difficulties in the beginning. I will make sure that doesn't happen again with our next few lectures.
They love you too much, so don't.
It was lovely to be here. Thank you. Okay. Thanks so much. Bye, Sasha.
Bye-bye. Thank you, Meryl. Thank you, everybody, for this amazing session with Professor Cohen. Thank you very much.
Bye, everyone.